Do you want this?
I'll probably just use this. Yeah, it's just so.
Hello. Welcome. This is our first grand rounds for GREC and Geriatrics for the new school year. So yay, we're excited. Just a couple quick announcements before we get started. Our next grand rounds is October 17th, and that's Windy Court. Exciting. Look forward to that, and that's going to be a historical grand round review. Our next journal club is October 17th for Windy. Next journal club is September 12th via Zoom. There is a geriatrics division meeting following today's presentation, and following grand rounds, you'll receive an email with a link to recording of today's presentation. Also included in the email will be a link to an online evaluation. Feedback is important, only takes about 2 minutes. And if you have questions online, please submit them in chat or in the Q&A boxes. The room's packed. I love it. Great to see so many people here early on a Thursday. So with that, I will introduce our speaker. I'm really excited to introduce Dr. Alex Garbin. Alex got his undergraduate and PT degrees at St. Louis University and subsequently did a PhD at the University of Southern California focused on fall risk in multiple sclerosis. And subsequently, he came out here to Colorado and did a 3-year GREC fellowship, advanced research fellowship with Jen Stevens-Lapsley, focused on older adult fall risk. And we're really excited because during his fellowship, Alex submitted a CDA2 and got a great score and was funded. And so his CDA2 is going to start here within probably the next couple months, fingers crossed, pending some VA specific issues. But Alex will talk about that a little bit at the end of his talk today. So without further ado, Dr. Alex Garbin.
Okay, terrific. Just to confirm, can everyone hear okay on Zoom? I have the chat open on my screen over here. Wonderful. Thank you, Katie. So yeah, my name is Alex Garbin. Really happy to lead off the grand rounds this year. As mentioned, I'm an assistant professor in the PT program here, as well as a health research scientist at our VA GREC. And I'll be talking about my line of research today, focused on identifying and reducing fall risk in older adults, as well as older veterans. For my disclosures, I have no financial disclosures, but the contents of this presentation do not represent the views of the Department of Veterans Affairs or the United States government. So as a brief outline for this presentation, we'll really first start talking about what is the problem of falls, really why am I invested in identifying and then subsequently reducing falls in older adults. And then I'll talk about really 2 areas of research, our projects that are focused on identifying fall risk and our projects that are focused on reducing fall risk. So starting with the problem of falls, I'm not going to belabor this point because I think a lot of the geriatricians in this room know falls are not a great thing for older adults, but I am going to kind of go over the general statistics that you see in most falls presentations, namely about 1 in 4 older adults fall each year, and these have a number of detrimental health outcomes. Notably, ER visits every 11 seconds, a fall-related death every 19 minutes. They are the cause of 95% of hip fractures, 51% of traumatic brain injuries, and I believe Josh had informed me a while ago also that they're the cause of the majority of spinal cord injuries. So really a clear impact on health outcomes, and I'd say, unsurprisingly, a clear financial impact as well, as they incur a cost of about $50 billion per year in the US alone. So clearly falls are a critical issue in our older adult community. And I always like to show what our older adult community is going to be looking like to show that it's a pressing issue and something we really need to be understanding and reducing, considering our older adult population is continuing to grow. So this is a nice graph from the US Census Bureau in 2014, where they plotted out essentially the number of millions per each age category for both females and males. And you don't really need to understand the graph too well, except for just seeing the growth in the size, especially from the 60+ range when they project our population out to 2060. You can see there's many more older adults that will be represented in the United States alone, and really many more older adults that we need to be preventing falls in so we can avoid these detrimental health outcomes. Now, a lot of my work focuses on veterans specifically, and specifically older veterans. So I also like to note how many older veterans currently exist in the VA infrastructure. And of about the 16 million or so veterans that existed in 2021, 8.1 million were over the age of 65. So just under 50% of our veterans are 65 years and older, and therefore could be really heavily impacted by falls, and therefore heavily impacted by ways that we can actually identify and reduce those falls. So again, I won't belabor this. We know falls are important. We know it's something that we should be reducing and really just trying to prevent in our adults age 65 years and older, especially. So moving on to our projects, the first one I'll be discussing is our implementation of routine walking speed assessments. The data I'll be talking about is from an IHQSE Clinical Effectiveness and Patient Safety, or a CEPS grant. We also have done some work in the VA Geriatric clinic, the clinic serving primarily older veterans. But again, the data I'll be discussing is from our UC Health Seniors Clinic. This was a quality improvement project with data collection having been completed. At least the data will be showing. And I do want to call out really the great team members we have. And there's many more individuals that aren't even on this slide. But special thanks to Jen Stevens-Lapsley, Mike Body, Hillary Lum, Thomas Johnson, Caitlin Allison, and Sarah Beck. So for those that have seen this video, I'm sorry, but I think it's a really nice way to show the importance of gait speed. So it's a nice whiteboard video we created. And make sure. A little quick 2-minute video.
Walking speed is increasingly becoming known as the 6th vital sign, alongside others such as heart rate and blood pressure. Because it is a fast, safe, and easy measure that provides insight into older adults' health status and function. Walking speed can be used to enhance healthcare providers' referral decision-making process and help older adults get the care that they need. There is substantial evidence for the value of walking speed. Studies have shown that a slow walking speed is highly predictive of adverse health events, such as falls, hospitalizations, or even death. And it is informative of older adults' functional independence. For instance, older adults walking less than 0.6 meters per second are at a high risk of falls and likely require significant assistance completing activities of daily living. Meanwhile, older adults walking greater than 1 meters per second are at a low risk of falls and typically able to do everyday activities, such as yard work or shopping on their own safely. Importantly, walking speed can be improved, and improving walking speed is associated with living longer. Clinically, walking speed cut points have been established that can be used to help identify older adults in need of formal rehabilitation. For example, older adults walking less than 0.6 meters per second would be considered high risk, suggesting they may benefit from a referral to rehabilitation services, such as physical therapy, to reduce their likelihood of future falls and enhance their functional independence. Walking speed can also be tracked over time, and a slowing of walking speed may raise alarm bells and prompt further evaluation to understand exactly why this walking speed is slowing. The value of regular walking speed measurements is clear. Incorporating walking speed as the 6th vital sign into clinical care supports clinician referral decisions and helps older adults get the care they need.
Okay, so again, it's just a video we like to show to really emphasize here's how walking speed can be used, and really here's why we want to make it that 6th vital sign or something that's routinely measured as part of primary care visits. Just to emphasize a few points from that video, why do we want to measure walking speed routinely? Again, it's that key indicator for health status and function that's really associated with a number of different health factors, and it's supported by really extensive evidence. It meets care providers' eagerness for a scientific and objective basis that can enhance referral decisions. And speaking with providers, typically what we've learned that measurements of mobility typically are reliant on self-report or just reporting maybe what you're seeing using something like the Johns Hopkins highest level of mobility. And again, by having this nice scientific and objective basis that you can look at both cross-sectionally and longitudinally, it can help support those timely and appropriate referrals. So based off of all this evidence and really all this value of walking speed, we're really trying to make a push to become really that research group and health center at the forefront of a nationwide initiative to routinely measure walking speed in all older adults. And again, using primary care as that opportunity. So in speaking of the evidence, I always like to show this slide by Middleton, Fritz, and Lusardi, in which they've really amassed a lot of different evidence represented by each square based off of different walking speeds. So if we look at the x-axis, this going from 0 on the far left to 1.4 meters per second, we can see that there's a lot of information about a slow walking speed. So if you're walking less than 0.6 meters per second, we know there's an increased risk of adverse health events such as death, hospitalization, or falls. These individuals are typically much more dependent, likely to be discharged to something like a skilled nursing facility, and again, have a much higher degree of frailty. In our middle group, the yellow flag, these individuals still are at an increased risk of adverse health events, but are typically more likely to be those limited community to community ambulators and are more likely to be able to be discharged home. And our green flag, those walking the fastest, are much more likely to be independent. So they're walking greater than 1.0 meters per second. They're more likely to be able to complete their activities of daily living, and they're at a much lower risk of adverse health events such as hospitalization or death. To show some specific data, this is a nice really aggregation of a lot of different studies by Studensky, where they looked at walking speed at baseline and then look at days to death over a number of different years. And again, based off of that baseline walking speed, they were able to create 3 groups. We have our less than 0.6 group represented by red, our 0.6 to 1 meters per second group represented by yellow, and our group that's walking greater than 1.0 meters per second represented in green. And what we can see is that there's really marked difference, I'd say, days to death of the percent being alive at certain time points. Looking specifically at day 3,000 or 8.5 years after that baseline gait speed was initially measured, we can see that the group that was walking the slowest, again, less than 0.6, had 55 to 60% still alive. In that middle yellow group, 70 to 82% were still alive. And in those that were walking greater than 1.0 meters per second, 90 to 95% were still alive. So I always like to look at the ends of the spectrum in this figure just to get the point across that there was about a 30 to 40% difference in percent alive just based off this stratifying on what was your gait speed 8.5 years ago. And I think that really shows that walking speed is predictive of mortality, but more realistically, I think at that baseline time point, it was very informative of health status and function, which then in itself was being predictive of that mortality or longevity. Now, importantly, walking speed can be improved. That single time point is informative, but it's not the end-all be-all. And we've seen studies that have shown what occurs, again, to that likelihood of living based off of improving walking speed. So in this study by Hardy et al., they looked at improvement of walking speed over a 1-year period, and again, created 3 groups. One that improved over a 1-year period by 0.1 meters per second and sustained that improvement, that's in green. Those that transiently improved, so they improved by 0.1 meters per second, but they were not able to sustain that improvement, and those that never improved. And again, we see this marked difference in the percent alive at 9 years, with those that never improved having 50% still alive, and the individuals that improved at 1 year having 70% still alive. So it seems that this ability, or really just the improvement of walking speed, can be highly impactful as well. And again, it's important to emphasize, especially when we're talking with patients, that walking speed is modifiable and something we can improve, and in turn also improve our health status and function. So all that being said, again, there's extensive evidence, but how do we actually use this clinically? How do we measure walking speed? And there's 2 ways we've used this approach, and really 2 ways we're continuing to use to measure walking speed. One is just the classic approach of let's use stopwatches. We have a 4-meter time track. We have them walk, and we time when they cross the starting line and then they cross the finish line. We typically also have a deceleration zone just to try to have this kind of steady state walking speed during the process. I just wanted to point out that we use a 4-meter, but you will see a lot of different things in the literature, up to 10-meter, 25-foot. We found in clinical spaces, 4-meter works the best just based off of constrained space to be able to do this. We also have used an automated system. So we've had a nice collaboration with an engineer at Georgia Tech, where he's been able to create some prototypes for us. And essentially, if we can see here, an individual will come in and get weighed over at the far end. And as they walk to their room, the MA or medical assistant will hit a blue button here. And then we have sensors that will just trigger each time a person passes them. And then as they walk past that, the screen at the end will say, how long did it take them to pass these two sensors and what was the meters per second? So in the MA, instead of using a stopwatch, can just look at this screen and quickly input it into electronic medical record. So for our project from the IHQSE SEPS grant, again, we implemented walking speed into the UC Health Seniors Clinic, and we had a number of implementation strategies that I want to point out. First, the automated system. We employed this again to really reduce burden and try to integrate it into nursing workflow as well as possible. We had a number of environmental supports to support that training to say, this is how you can measure walking speed consistently so that we don't always have to be hands-on. And also this is how you can input that walking speed into electronic medical record. We had some good timing in that we were able to integrate walking speed into the electronic medical record very quickly, both for the medical assistants as well as the physicians. And we also had clinical champions, again, both for the medical assistants and the physicians. Another aspect is we have patient and provider facing materials. So these are essentially if a patient comes in, has a walking speed below 0.6 meters per second, we had handouts that we provided to providers to say, this is how you can talk with your patient about this, and here are some recommendations, whether it's physical therapy, community exercise programs, or just general recommendations to increase their physical activity. And then in addition to this, we had a number of provider education meetings and also say meetings with medical assistants to get their feedback and again, provide them that support that was necessary. So all this being said, did these implementation strategies actually work? And to show just one implementation measure, I'll be focusing on reach today, which for us was the proportion of patients that had their walking speed measured when they came in, or I'd say more accurately, the proportion of patient visits that had an associated walking speed measurement. And to orient you to this figure, on our x-axis, we have weeks, and it's aligned to the week of the year, which is why we have it started at 42. It's about a 40-week span. And on the y-axis, we have the proportion of clinical visits that had a medical assistant note with walking speed entered. So essentially, you can think of it as the number of clinical visits or the percentage of clinical visits with an associated walking speed. And what we saw was a pretty quick ramp up early in the first month, up to about 60%. So 60% of our clinical visits had an associated walking speed, and then a gradual ramp up to the end of about 70%. And I'd say we don't have data that we've looked at specifically past this point. It's been about a year, and I think we've been able to really sustain that 60 to 70% reach throughout this process. With regards to burden, again, we use this automated system in an effort to really reduce burden, and we integrate it into the workflow of the MAs, again, to reduce burden as much as possible. And we wanted to see, were we actually reducing this burden as captured by how long did the walking speed measurement take? So we assessed 118 clinical visits with a research assistant, essentially shadowing these medical assistants. And what we found is that the addition of walking speed added a median of 19.5 seconds to rooming procedures, which we were very encouraged by, given that a lot of the literature in walking speed has shown that typically using a stopwatch can add about 90 seconds to rooming procedures. So this was very low burden, and I think one of the reasons that we had our reach of about 60 to 70%. And aligned with this, I think it's one of the reasons that in that 10-month period, we were able to measure walking speed during 4,000 patient visits. Again, it's been about a year since this point, so I think we're closer now to about 7,000 to 8,000 patient visits with an associated walking speed. Now, a question that we also had is just what's the actual impact of measuring walking speed on our patients' health outcomes? And the way we wanted to look at this was, does measuring walking speed result in any changes in their actual walking speed? So again, to orient you to this figure, on our x-axis here, we have the change in walking speed. On the y-axis, we have an individual's initial walking speed. And we looked at walking speed only in those individuals, or at least in this figure, that had an at-risk walking speed as indicated by a baseline walking speed less than 0.6 meters per second. What we found was that in these individuals that had at least two walking speeds separated by 180 days, that they improved their walking speed by a median of 0.07 meters per second, which again to me is very encouraging, especially because the literature demonstrates that typically in adults 65 years and older, they'll actually have a decrease of 0.04 meters per second in a year-over-year period. Now, that being said, this isn't causal. It's a single group, so we can't really establish causality in this. But a few potential really ways this might have occurred. It's possible just the presence of walking speed could have encouraged individuals to be walking faster in their day-to-day lives. We were giving recommendations to providers for these at-risk individuals, again, for things like physical therapy, physical activity promotion, or community exercise programs. But again, we can't discount that there could just be some temporal thing that's happening that was encouraging change in walking speed, or statistically, regression to the mean is always possible. So we're hoping to look at this in a more rigorous way in some future research studies to really understand, does our actual implementation of walking speed improve health outcomes and improve walking speed? And we do have a few additional results collected by, again, a lot of our team members. Thomas Johnson did a really great job collecting a lot of qualitative data. And I'll be presenting more of this research at the GSA annual conference in November. So just a quick shout out if anyone's there. I encourage you to hopefully attend. There'll be a lot of other great researchers across the country also sharing their data on implementing walking speed and using some aspects like a mobile app to measure walking speed. So what is our future work in this line of research? Again, I showed you data from our UC Health Seniors Clinic, and we've also really had a lot of lessons learned from measuring walking speed in the Geriatric clinic using a stopwatch. And we really coalesce these two things for a merit award in the VHA merit proposal, in which we're going to be looking at using a hybrid type 2 design, both the implementation and effectiveness of implementing walking speed across 6 primary care clinics in our local VA vicinity. So moving on to another project in which we're really identifying fall risk. And this is an ongoing and near to be completed project that was a VA Repair REAP award, in which we're looking at the prevalence and perceptions of falls, fall risk, and risk factors in older adults. And this is a cross-sectional study. And again, thanks to Jen for this help, Sarah Beck again, and then research assistant Mackenzie Fowler and Audrey Kellerman. So really the motivation for this study was, while collecting walking speed in primary care, we just noticed there was a few gaps. Notably, there was really a limited understanding of fall risk in older veterans, specifically older veterans that are being seen in primary care. And it was difficult to take what we already know in the community and apply it to our older veterans, considering these key differences. The one I always like to emphasize is that a lot of our fall knowledge in the community has typically a large proportion of females being represented because females are more likely to fall. For older veterans, about 98% of them are men. So immediately that makes it really difficult to translate what we know in the community for older veterans. And then we also wanted to know just perceptions. Because we didn't see fall risk frequently being assessed or managed in primary care, and we really weren't hearing it voiced by veterans just when we were seeing them, we wanted to know, what do they think about it? Is it important? What barriers might be existing that we're not perceiving just by kind of having boots on the ground in the clinic? And all this together, both the prevalence and the perception, was really meant to guide intervention development. So again, we were looking at prevalence first, really doing different assessments using VA Video Connected Telehealth Platform, where we're first asking just what's called the three key questions, which is taken from the study protocol, where you ask, have you fallen in the past year? Do you worry about falling, or do you feel unsteady? I'm sure many of you have asked that or been asked that if you've gone to the doctor. Based off of this, if they answer yes to any of these questions, they're considered a fall risk just per the screening protocol. And if they answer yes to the first question, we key them as someone that has fallen in the past year, again, for looking at the prevalence of falls that have occurred. We then wanted to expand this to look at specific fall risk factors. And we really anchored ourselves to these 4 fall risk factors: physical, lower extremity strength and power; psychological, being fear of falling and activity restriction; environmental, being home safety; and then pharmacological, focusing on fall risk increasing drugs. So again, we want to know what's the prevalence of these individuals screening positive for these specific fall risk factors. Again, in line with this, we also wanted to know just what are these different perceptions, both of the veterans that are being seen in this Geriatric clinic, but also of the Geriatric providers. So we asked again, what's your experience with fall risk screening, identification, and management? Essentially, has this occurred? Are you aware this has occurred during your visit? And if so, what are your thoughts on it, of its importance? We also asked about barriers and facilitators, again, for both fall risk identification and participating in fall risk management. Because we're really pushing, ideally, to have an intervention that is anchored, again, to telehealth, or at least access to these interventions using telehealth, we wanted to ask veterans what their perceptions of using telehealth for fall risk identification and management are. And of course, we want to say, essentially, is this important? If we asked all these questions, looked at all this prevalence, then at the end, everyone said, I don't care about this. I'm not going to participate in this because it's not important to me. We really have to take a step back and say, what do we need to do, at least to show that it's important or engage these individuals? So results, again, ongoing study, can't show results, but I will be presenting this also at the GSA conference, again, focusing on other virtual implementation programs. Jen Stevens-Laps will be presenting as well, Michelle Rousey and Kay Ritchie talking about, again, these different telehealth type programs where we're either assessing factors or trying to intervene on factors. So Again, a little plug for that. What I can talk about is just what have we learned from using, again, a telehealth platform, VA Video Connect, to do fall risk factor assessments, because this is really the most important thing during this is, can we actually use this and can we do it safely? So we have a single physical function test, the 5-time sit to stand, and we really chose this test first because it's shown it can be done using virtual platforms, and it's shown that it can be done safely. Again, avoiding falls during this test was paramount to me because I don't want to have a fall while I'm studying falls. So what we've done really as part of our protocol is ensuring we always have a secondary person available. That makes it hard sometimes for recruitment, but just so that if someone begins to lose their balance, they have that support individual that can, again, help them steady their balance. In a similar vein, ensuring setup is safe. So having a chair that's against a hard surface that's non-mobile, and ideally having a hard surface opposite of that support person. So essentially you're just limiting the degrees of freedom where a fall could occur. And then for surveys, we essentially wanted to make sure that the veterans on this call can understand surveys. If any of you have done VA Video Connect or telehealth visits, audio can be an issue at times. And sometimes they just don't have the audio for their computer, or if they have hearing aids, it presents a challenge. So we've been able to create some nice PowerPoint presentations that essentially walk them through each survey, each questionnaire, and has been received very favorably by the older veterans that have participated in this study. So moving on to the final study, and this is my CDA study that Josh mentioned. This is, again, a career development award for those that are unfamiliar. It's similar to a K award, in which it's a 5-year project in which you have funding to do this project. Typically, it's a project that's meant to build your portfolio to kind of the next stage. And the important part of it is that it has associated training, again, to allow you to fulfill your project and grow as an investigator, and again, really be that early career researcher within the VA system. My mentorship team at the bottom, of course, wanted to give a big thanks to them: Jen Stevens-Lapsley, Jerry Forster, Liz Goldberg, and Meredith Mueller. So thanks to them for the application, and really thanks to everyone who's helped on this application process so far. So this project is the fall risk identification and management model, and there's 2 phases that I'll go into a little bit more detail. The first being this initial refinement phase, and the second being a randomized feasibility pilot. This is a future project with, I'll say, an ideal start date of October 1st. Fingers crossed, as Josh said, you never know with the VA. So what's the motivation for this? Again, it's just kind of lessons learned and looking at the literature. But the biggest thing is that from our experience and talking to individuals, fall prevention in the VA is typically more of a reactive thing. They might try to act on that fall risk after a fall has occurred. And I'd say that's no fault to anyone. Providers are often way too busy, especially if we're thinking of the Geriatric clinic. There's a number of competing priorities because these individuals have a number of comorbidities and aren't typically coming into the clinic because they're saying, I want you to address my fall risk. It's that they want their medications changed, they have a new onset of pain, or maybe they just want their driver's license and it's not happening. So typically is not really the priority is what we're hearing. Now, that being said, we do know that there are several multifactorial fall prevention resources available in the VA. The VA is great for the development of resources, the development of programs, and we really have been able to align these with different fall risk factors we know about. But that bottom bullet point really was the big question: is how do we actually connect our older veterans to these resources we know are available before that fall occurs? So really in a preventative way. And a piece I like to emphasize whenever I talk about fall prevention work, really my mantra for fall prevention work, is we don't need to reinvent the wheel. We know what fall risk factors are. We know how to reduce fall risk factors. In that sense, we should know how we can reduce falls in our older adults and our older veterans. Now, in a similar vein, there have been a couple of studies that have done a similar type of model in the community, identifying fall risk factors and trying to reduce those fall risk factors. That said, I think if you talk to their researchers, and I have, they've said the results weren't quite as promising as they had hoped or as their model had hoped. And there's really a number of different kind of lessons learned we could take from those studies as well. Namely, they used a number of fall risk factors. Again, I've anchored myself to those 4 we talked about before. Some of these studies have used upwards of 7 or more. And in doing that, you can't prioritize every fall risk factor that someone has. So they've had to let the patient or the physician choose the fall risk factor they're addressing, which can end up with certain fall risk factors being addressed that maybe are lower importance. In the same vein, there's a lot of benefits of the VA system that can reduce certain barriers. One main one being if you're referring someone to a number of fall prevention resources or different referrals, this can be costly. Where in the VA, if this is a covered aspect or if the veteran is covered within the VA system, that monetary barrier is essentially ameliorated. So it's a really nice benefit of the VA system, as is the fact that a lot of these different services are talking to one another. So it's a little bit easier to track someone from referral to the actual receipt of that fall prevention intervention. So I'll walk you through the, again, fall risk identification and management model. And I have a couple of examples just because feedback I've gotten is it can be a little confusing, but it's really a three-step process. The first being primary care. We're still doing one component of primary care, but it's really just those three key questions. So we're trying to minimize as much as we can the work needed either by that nursing staff or the providers. So the veteran comes in, and again, they get asked these questions of, do you feel unsteady? Do you worry about falling? Or have you had a fall in your past year or since your last visit? And if they answer yes to any of these questions, they're then referred to a subsequent visit using VA Video Connect telehealth, again, using one of our research assistants or myself, where we'll be assessing these different fall risk factors. Again, physical, using the 5 times sit to stand, psychological, using the survey activities of fear of falling in the elderly. This looks at both fear of falling and activity restriction. We've used this because activity restriction can be especially impactful in older veterans and can make them really at a much higher risk of falls. Pharmacological, we're looking at fall risk increasing drugs using what's called the stop fall, and environmental using home hazards. Initially, we started with the Westmead, but using this on the telehealth platform where you ask about 60 to 70 questions became a bit arduous and we had some negative feedback. So we've shifted more with what's called the home fast, which is a much briefer, but has a pretty good predictive ability on falls. The subsequent step is if individuals screen positive for any of these fall risk factors, again, they're referred to a VHA care pathway. So if they screen positive for physical fall risk, they'd be referred to strengthening and balance using something like physical therapy or Gerifit, which is a supervised exercise program put on by the VA. For psychological, they could do cognitive behavioral therapy of clinical psychology, but occupational therapy can also do this. For pharmacological, it'd be medication reconciliation or deprescription with clinical pharmacy, and environmental, that addressing home hazard can be done by occupational therapy. And one thing to emphasize again, this first aspect, the identification of fall risk, we learned a lot from this past year and using the REAP project. So we'll still be doing this using VA Video Connect, safely assessing these fall risk factors. And then for managing, this can be both in person or virtual. And I think this is important because a large barrier, we just kind of anecdotally heard, is that I don't want to drive into Rocky Mountain Regional. I live 30 minutes, an hour away. So that's going to be the reason I don't participate in this fall risk abatement program. In a similar vein, we have a lot of rural veterans in Colorado. So by having this virtual option for both identification and management really opens the door to have a lot more older veterans be able to participate in the program. So again, I like to give examples of this just because, again, it can be confusing. So in this first aspect is just Sally. She comes into the Geriatric clinic, says she's worried about falling and feels unsteady. So she's referred to the identification process using VA Video Connect, where she has a psychological fall risk factor. So she has both fear of falling and activity restriction, and a pharmacological because she's taking 5 fall risk increasing drugs. So based off of this, she is referred to the management section, where she's referred to cognitive behavioral therapy to reduce that fear of falling, and medication reconciliation to ideally reduce the number of fall risk increasing drugs. John is the opposite example. He comes in and says he experienced a fall 1 month ago. So again, that is a positive screen, and he's moved towards the identification process where he scores a 20 seconds on the 5 times sit to stand, which is a positive physical fall risk factor, and he has 10 home fall risk factors. So again, positive on the environmental. So he's referred to physical therapy to improve that physical function, and occupational therapy for home safety assessment and modifications. So as mentioned, there's 2 phases of this project. The first phase, which is about 1 year long, is really field testing and partner interviews, where we're going to have 10 veterans go through each pathway, ideally. And this phase is really meant to refine the program before our subsequent phase. So in this, we'll just first see if a veteran goes through a certain pathway, what does it actually do to that fall risk factor? So if someone goes to the physical fall risk pathway, is it improving their 5 times sit to stand? Or if they're going through the pharmacological fall risk pathway, are they reducing the number of drugs or the dosage of these drugs? We'll also be having interviews with participating veterans and clinicians in this program, just to understand what aspects can be modified. Should we have a different fall risk factor? Should we have a different cutoff score for some of these fall risk identification metrics? Again, and a means to just refine this before that subsequent phase. So our phase 2 is a randomized feasibility pilot, and just the top figure here is showing the timeline of it. We have our initial baseline fall risk factor assessments, again, during that identification phase, and then individuals are randomized either to the fall risk identification and management model or to standard of care, with 34 being in each group. Over a year period, then, we'll be monitoring falls and injurious falls using what's called the Annie app, which is a text messaging service, where essentially weekly it might ask these veterans of, have you had a fall? And if they have had a fall, there's branching logic to ask them, was it injurious? How many falls you had? So we can have this nice granular data on falls. And we'll also be looking at the medical record to see if we can capture falls that way. 1 year post-baseline, we'll be looking at fall risk factor assessments to again see, does this actually modify these home fall risk factors by participating in this program? Now, this is all the efficacy data, but that's really not the primary goal of this randomized feasibility pilot, but we are collecting efficacy data so we can look at the variability, marry it to what we know in the literature to ideally then power that subsequent efficacy trial. The primary outcome is feasibility, and our primary feasibility outcomes are of the individuals that are screened, how many are actually recruited into our program, and then what is our 1 year retention rate. And again, we're also looking at acceptability. We'll be using questionnaires as well as interviews, again, with veterans that participate in the FRIM model, as well as clinicians. And this is based off a theoretical framework of acceptability. So again, this is the Career Development Board, a 5-year program. That phase 1, just to emphasize, is our refinement. Phase 2 is the feasibility pilot. We're trying to enhance that feasibility to then lead into an efficacy trial and ideally a merit award to be submitted in about 5 years. So that is really all my line of research. I also wanted to emphasize this talk that is coming up. I'm sure many of you are aware that a lot of us have really helped to push. I think it's really nice topics that I encourage anyone, if you haven't signed up, to sign up for. And of course, thanks to everyone that I've noted already, and thanks to everyone that I haven't noted, and big thanks to the Restore team as well. Thank you.
Well, we'll open this to questions in the room and or online. I don't have my computer pulled up, so I don't know if there's any questions in the chat.
Yeah, I do have the chat box open, so feel free to ask there.
So I have a few questions, Alex. First off, that was a great presentation. Loved it. It pulls at my heart because my mother is elderly, as probably many of ours are in this room, and she's fallen and she's had injurious falls. And so a really quick question would be, you know, she's on Medicare, so it's hard for her to get into PT.
Yeah.
It's hard for her to get to referrals. What could our clinicians here in clinic, or what could non-clinicians do really simply to potentially reduce fall risk, knowing that there's a lot of causes of falls? Is there something we can be doing to help with this?
So it's hard to say simply, just because falls is kind of bang the drum that is multifactorial. There's not a single reason someone's falling. Someone could have perfect physical function and still fall just because they trip on a rug in their home. So again, there is general guidelines. The typical one right now is the study protocol, where you can look at different fall risk factors. But I'd say more often than not, that physical will be the key thing. And while PT can be very hard to get into, especially at UC Health, I think giving things like physical activity improvement, silver sneakers, there's so many great community exercise programs at this point that we can refer out to, and in turn, ideally get them, again, improving that physical function or learning about reducing fall risk while not having to wait 3 months to get into physical therapy. So I'm a pretty big advocate of community exercise program, and we've tried to reduce the barrier to entry, because even sometimes that can be difficult to find for older adults.
Thank you so much, Alex. 2 questions. One is, when I talk about this in the community, they always want the gait speed monitor. And I understand that the Georgia Tech collaborator is overwhelmed and isn't able to provide them. And so do you have any data on how well uptake is with the automated system versus the stopwatch system?
So in UCL Seniors Clinic, we started with stopwatch, and I'd say it went rather well. They definitely prefer the automated system because it is reduced burden. But I would say it's much easier to go from stopwatch to automated or stay at stopwatch. What's difficult is to go from an automated system to the stopwatch. So if you're not aware of an automated system, I think it's okay. There are a few phone apps as well, and we're talking about the community that when I've given talks, you can put it in your pocket and walk across the room, and it'll tell you this is your walking speed. Not at a great granularity, but it's at least some information they can have. One of my presenters or co-presenters at GSA, Amy Lowe, as well, over at Harvard, They have a really nice phone app that is not public yet, that I'm hoping will be public soon, where I can do it over a 4-meter course, and I think give you that more granular walking speed. So we're always keeping kind of our ear to the ground to say, what are some ways we can do it? But I think for scalability, our preference is still stopwatch, just because it is easier. And if they're true, it's not a huge burden, but it's just a little burden.
Great. And then the other thing people ask is, you say, the faster you walk, the longer you live. And they'll say, but what about those people that are impulsive and they're walking too fast to be safe?
Yeah, so I never talk about, it's a U-shaped curve technically, which always adds a bit of confusion, where if you're walking quicker than 1.4 meters per second, it can technically increase your fall risk. I never say that to older adults because I don't want them to be afraid of walking fast, because typically I've never seen someone walking that fast in all of our clinical collection. I'm an ambler, I can't do it. It's very fast. But yeah, it's something to think about. A lot of my research has also been in fear of falling, and there are these kind of categories of these individuals that are a very high physical fall risk, but not perceiving it. They can be falling because of that. So a lot of times it's, do they have the capacity to walk that fast, or are they trying to put themselves above their capacity? I think that's when it can get dangerous. So we're never just saying, hey, walk fast. It's, we need to improve your function so that you can walk fast, which sometimes needs some subtle messaging.
Alex, I've learned when I got my first VA merit that when the VA says you have to enroll veterans in your VA-sponsored research, they don't mean any veteran. They mean veterans who get their health care through the VA system. And becoming eligible or being eligible for VA health care has some stipulations. Not all veterans are eligible. So what I'm trying to say is that the VA is probably a unique setting. When you had that slide up for why you need to have a VA specific model, I think one of the factors you need to put in there is that those veterans may have had some unique exposures to toxins or other hazards of warfare that distinguish them from the general population. So my question is, have there been any comparisons of veterans and non-veterans in terms of risks for falling, and whether there needs to be a veteran-specific intervention model because of the unique population?
The biggest unique aspect that they've really not explored it, and I'd say great detail of what are these different fall risk factors, is because, again, there's been less of an emphasis on studying falls, and even right now there's a push for creating a fall prevention center in the VA, I think, because we haven't been focusing on it. One thing we do know, again, is that activity restriction can be especially impactful, though. So there's a study that showed that veterans are typically less likely to fall than our community counterparts unless they have activity restriction. And then that really flips the script. And at that point, they're actually more likely to fall. I think because veterans are actually more active than our community counterparts is what we've seen in this literature as well. But I agree, there's some more nuanced, I think, risk factors that are worth looking at that could be associated with these different exposures. I think even just behavioral patterns. So talking of our walking speed project and talking with our veterans, one unique feedback we got actually multiple times was they learned to march at a certain cadence. Can that actually impact my walking speed? So that's something I'd be curious to look at eventually as we kind of collect more data, both in the community and the VA, is matching for a lot of things. Does walking speed now differ just based off these different behavioral patterns? Because I think there's a lot of seen and unseen differences between our veterans and non-veterans.
So in the complexity of older adults, I appreciate that you're identifying multiple fall risks, and even that you had to constrain to 4 risk factors, recognizing that there are more of them. So is there data that we can have an effect by addressing just one risk factor, or do we need to address multiple risk factors if multiple risk factors exist? Recognizing that both in interventions, but just also as humans, it is hard to do more than one thing at a time.
All the recommendations from the World's Falls Guideline do emphasize that multifactorial approach of you should be addressing multiple fall risk factors because one is likely inadequate. That said, I think it's much more likely that it needs to be individualized. And when we have these large clinical trials with 500 individuals, it might be that 100 actually just needed physical function because they're good on everything else. And when we've been doing our fall risk factor assessments, we have a number of individuals that are only screening positive on a single fall risk factor. So for them, if the reason they're falling is because their legs are weak, it might be adequate to address a single fall risk factor. But I'd say for the majority of individuals, that's unique, and that it's typically going to be multiple fall risk factors that we should be addressing, again, to reduce that fall risk as much as possible.
The next step then is, what are some of the things that you're going to explore of really how to help us as clinicians in the system to address multiple things at the same time?
Yeah, so it's much easier in the VA where I can say there's these resources, refer them out to here. And I think beyond the VA, then it's exploring in the community, how do you have that not loss in that middle ground where if you are referring to occupational therapy, physical therapy, and psychology, what's the likelihood they're actually going to be followed through to each of these, or are they going to get lost in that middle zone, which I think we see so much, that you can have the referral, but you don't have the referral follow through. So that's one thing I'm going to be looking at really closely, especially in that first phase. And in the VA, how many individuals are we having to kind of keep in touch with and push to have that referral follow through and talk with the clinicians? And if we move this towards the community, I think that'll be an even bigger imperative because it's more challenging not being this nice integrated healthcare system.
Thanks for a great talk. I really appreciated the slide on the mortality risk. And I was wondering if you could talk a little bit about, as patients potentially progress to needing a wheelchair, or at the VA specifically, motorized scooters, is there any data that you know of? I'm sure there's data out there, but anything that you're familiar with in terms of like potential mortality risk as people progress to those additional aids?
I'm not familiar with wheelchairs specifically of like, essentially, is that a stratifying factor that increases mortality risk? I recall from years ago when we first were talking about this of, we can't measure walking speed individuals, obviously that are constrained to a wheelchair. Is there an alternative, whether it's even just wheelchair mobility speed? And I want to say there's research in that. It feels like it's fleeting in the back of my mind, but I'm not able to pull it up right now. But that has been a conversation we've had historically, because those are the individuals, obviously, that can't do this vital sign that we're talking about.
I also was intrigued by the mortality data. And I guess my question would be, do you see walking speed as a surrogate for adverse health outcomes like mortality? Or is this directly impacting hypokinetic disease risk? And how does walking speed compare to other predictors of hypokinetic disease risk or mortality, like grip strength? That's really easy to implement.
Yeah, so there's a little bit of research comparing walking speed and grip strength. Not a ton, but they've seemed to be roughly equal, I'd say, in their predictability, as well as the timed up and go is another one where we see it's typically comparative. We've chosen walking speed because grip strength, you require a little bit more devices, a little bit more setup of even changing the system based off of their hands, the size of their hand, and then timed up and go. Obviously, you need things like a chair, cone, things like that. So we've tried to pick essentially what's the minimally intrusive aspect of all these that are similarly predictive, and I'd say more informative of that health status. Because to me, that's what they're all doing. It's just saying, is a surrogate for what's my status, what's my physical function, mobility in this current state. And because of that, it's being predictive of these adverse health events and mortality and hospitalizations.
Thanks again for a great talk. In the seniors clinic, I've noticed that there's some variability in gait speed over time. And I'm just wondering about any data or understanding you have about, because I see some patients and they'll have, one or two decreased, decrements in gait speed, but then it will recover and it may be associated with an acute illness or, some other medical issue that's going on. And I've been surprised to see the degree to which people can improve without necessary interventions. And I'm just wondering, is there any value or in looking at gait speed over time, like having two subsequent measurements, does that further predict outcomes? Does that further stratify folks into high risk, low risk for,
Yeah, so we have two main recommendation, I'd say, pathways. The first being that if you're less than 0.6, that's the red flag. And then I think even in our EMR, it keys them as this red flag that ideally is giving notice to the providers. The other being, at least that we've tried to talk about, is if they are slowing down by 0.1 meters per second, because that can either be this gradual decline in function over time that we're capturing with walking speed, or it can be an acute illness, onset of pain, new medications not reacting well. So that's really our two main recommendations right now, and for all of our future work is cross-sectionally, yeah, but to me, I actually think longitudinally can be more important because you are able to capture, again, these quick changes in function that otherwise may go unnoticed.
Alex, do you see gait speed as the cart or the horse? Does slow gait speed cause people to develop chronic comorbidities, or do they develop chronic comorbidities that leads to low gait speed?
I think they have a low gait speed because of the chronic comorbidities. So I don't think gait speed is causal. The only thing it might be causal in is it could increase someone's risk of falls because with the lower gait speed, you typically are going to be in that single limb stance a little bit longer. But that's the only one that, from my perspective, is causal. Now that's just my perspective. But again, I think it's more of that window into function rather than the thing that's impacting function.
Hey, Alex, thanks for a great talk. My question is more derived from the perspective of predictability. So I was curious if you're interested or if your group thought about retrospective analyses that from the context of what these patients may have gone through or experienced in their life that could predict their sensitivity to these interventions or predict the ability to start engaging in increasing walking speed or increasing gait speed. So more from like a mechanistic perspective that these preceding events could be then targeted to hopefully induce or transduce longer term beneficial outcomes.
No, so our group, I mean, admittedly, we haven't considered that in great detail. Like I said, this first project we looked at was more of a quality improvement project. So it was much more focused on just how can we put this into the clinic to improve clinical care. Now, when we are going to begin to collect much larger amounts of data, that's something we could potentially be looking at, especially in the VA with an integrated healthcare system with a lot of historical data available to us. It's something that might be a future project. But again, that would require a much larger amount of data in the thousands, which might soon be available to us or in the coming years be available to us. Yeah.
I wanted to build on what Wendy brought up, like the relationship between the causal kind of elements. And I think the reason that gait speed is such a sensitive indicator of decline is because it measures like systemic changes, and there's a cumulative effect of lots of little, comorbid conditions that are adding up to then result in a decline in gait speed. And you might not see the effect of each one of those in isolation, but because they kind of work together to affect mobility or contribute to a decline in mobility, you're more likely to detect that change sooner than individual diagnoses and I've heard enough people say that they saw a decline in their parents' gait speed before they got the diagnosis of A, B, or C. And so I think part of the reason why it's so sensitive is because of that, like all these different factors that contribute. Each one of these, you may not notice like a change in sensory or perceptual function in isolation, but when you couple that with cognitive changes and muscles weakness and all those things, that's where you start to detect, the deficit earlier.
Say to go along with that, we're physical therapists, so obviously we have a slight bias towards physical function, but a lot of the feedback we have gotten is that it's not always physical function. So I think we've kind of opened it up to now say, okay, if you notice a decline in walking speed or a low walking speed, use that clinical experience that you have as a provider to say, okay, what might be the thing that's causing this, not just physical function.
In my population, which is spinal cord injury that I look at a lot, I run across individuals who have an incomplete injury so they can walk, but they do so with significant gait deformity, but essentially propel themselves forward fast enough that they're walking faster than 1 meter per second.
Interesting.
How do you deal with something like that?
We don't, because we exclude them typically. But I think that is hopefully something we can do is look more at subpopulations and understand these subpopulations better that do have unique characteristics. Things like individuals with Parkinson's disease being a big one is we have a lot of this knowledge in the general older adult community that unfortunately can't be applied to individuals with maybe specific comorbidities. So I think that's something in the future we'll be looking towards.
Are there questions online to address?
One question by Kathy. So in study 1, were the interventions community or PT interventions to improve gait speed for at-risk individuals? So we had a number of recommendations, I'll say, based off, again, of that less than 0.6 or decline by 0.1. And they really would scale, I'd say, on commitment for the patient. Things like the top being physical therapy, going down community exercise programs. So we created a community exercise program sheet that we gave to, or we have placed in the clinic in case that was a better option. And again, physical activity engagement or community or just home exercise programs. And it's been fleshed out even more for merit award proposals that we have really specific recommendations we can give based off of that walking speed.
You mentioned that females are at higher fall risk than males. Why?
Don't know if they have an actual mechanistic understanding. I know there's also examination into race and its impact on fall risk and fear of falling. There's some there even just looking at physiologic differences in body shape, which can be contributing to it. And that might also be what we understand in females, that even just shapes of pelvis can have a great impact on foot placement and then in turn have a great impact on fall risk. But just typically we know that they're more likely to fall and more likely to have those injurious falls as well, potentially due to a higher likelihood of having osteoporosis.
I have another question, I guess. So I love this gait speed automated testing device. I think that's really cool. It's super innovative. It's takes the time away from the clinic. I'm wondering, versus stopwatch, I'm wondering, is there a way to connect that to the electronic medical health record so that it just shoots the data right in, which would even further reduce barrier?
That would be the ideal state. And I think would be the greatest reduction of burden. But to do that, like I said, it's an engineer at Georgia Tech who essentially is giving us prototypes. So they're definitely very far away from being able to integrate it into Epic or CPRS especially. But my hope is in the future that a company essentially is going to take the reins of this thing. And I think as we bolster it to say this is something we need to be doing, ideally we'll get some attention to say, hey, there's actual value in us being the company that makes this automated device that can be then married to Epic or married to CPRS. So I think that'd be the least burdensome way we can actually make that occur.
Other questions? All right. So thank you, Alex. That was a wonderful talk. Really appreciate you taking the time to come in and talk with us about it.
Thank you all.
On. There we go. We'll get going in 1 minute with our strategic planning.